Hi, my name is David Sallman from Moffitt Cancer Center in Tampa, Florida. I'm the myeloid section head, and really a pleasure to be at this EHA Congress in person. So, the clinical trial I'm presenting at this Congress is a combination of azacitidine with magrolimab. So, to take a brief step back, high risk MDS treatment has unfortunately not changed since 2006. We've not had a new approval other than basically an HMA equivalent agent. And although several doublet therapies have failed in phase 3 trials, we're really looking for that combination that's really going to change the standard of care. And so the presentation is actually on a very mature cohort of 95 patients with a median follow-up of 17 months. So what is magrolimab? It is a novel monoclonal antibody that blocks a don't eat me signal, essentially allowing for the activation of phagocytosis to occur. Preclinically, azacitidine actually can upregulate the pro-eat me signal calreticulin, and this really allows for the synergy between these two agents. So as far as safety, actually the combination is very well tolerated. There is an on-target anemia that's expected. So old red blood cells express these pro-eat me signals. It's basically our body's way of getting rid of these. And thus, particularly after the first and second doses, we can sometimes have large drops. So to counter that, we actually keep patients' hemoglobin above 9. We recheck them very frequently that first week, actually 2 checks on day 1 and day 4. And with that, we've been able to support patients with a very, very low 30, 60-day mortality at really 2% across the study. Other than that, we're not seeing unique toxicities and really not seeing the immune-related toxicities that we're concerned about, let's say, with traditional immune checkpoint agents. As far as efficacy, over 3/4 of patients are achieving response with true complete remissions between the 30 and 40 percentile based on if you're looking at p53 wild type versus mutant patients. At this Congress, this is really the first presentation of survival data. So again, with this follow-up of 17 months, we have a median overall survival that has not been met. But actually, if you look at our cohort, is very high risk with 26% of patients being p53 mutant. So then if you parse this based on mutation status, p53 mutant actually had a survival of 16 months. Although we still have a long ways to go, that's 6 months greater than really any trial to date in this setting. And then if you focus on wild type, over 60% of patients were alive still at data cutoff. At this Congress, we'll actually present the very initial transplant data, which looks quite favorable with over 70% of patients alive at data cutoff. And we're hoping that really these patients are getting deeper molecular remissions, which are then translating to better outcomes. Really, in conclusion, these data highly support the ongoing randomized phase 3 trial, the ENHANCE-1 trial, which is a double-blind placebo-controlled trial looking at combination therapy versus versus azacitidine therapy alone with a dual primary endpoint of CR, which will hopefully read out in the not distant future, and then ultimately overall survival. So again, hopefully this will change the standard of care for our patients.